Adenoma experience 20 year experience of 180 cases. Professor Sharif Yusuf.
Thank you, Mr. Jordan. Colleagues, I have been feeling very disappointed. My talk brief like is that people individually knows is it correct or not? Why I believe this? During past 20 years, we tried to colonoscopy. This is who we are. We are going. We have a great, for example, was sting surgeon, from vascular pathologist, endocrinologist, everything. We are able surgeon and we work in Tehran. We want to remove every pituitary and remove from two nose. Is it correct or not? I'm not sure. We have two obstacles to do this. One is the tumor texture. It's fearless. Is it bad or is it good? First, 20 years ago, I thought that it is bad. But later on, we changed to extracellular dissection and think that in some volume of tumor, it will help. Some volume of tumor. Another approach is that how we can reach the tumor. We do transplanum approach because we need and use transplanum approach for creating tumor and some meningioma. We try to locate it in pituitary adenomas. And I'm talking about these. For example, the classic here is the orange one, and transplanum approach we use the green one. These are many pathology that we can remove by the medical transtuberculum transplanum approach. Many kind of lesion we can remove it. This is the planum area that's in front of the tubercle, middle tubercle, and we remove it. This is the between 2021 and 25. We record all patients and we operate through the transplanum approach for pituitary and the group. Transplanum approach for pituitary. We have a very good GCR record and two cases of our cases develop postoperative ICH. And we will talk about postoperative pituitary ICH. It's needed another time. We had 5 leaks, and there's high removal of the larger skull base. We have 5 leaks and 3 cases of meningitis. One mortality because of meningitis that can relate to surgery. This is the case. Not any cases needs transplant of alcohol. If you see on the right side, you see that 60% of this tumor is above the level of skull base, above the jugul, above the lamina tuberosa. But it doesn't need transplant of approach. 80% of the look-like cases like this don't need transplant of approach because of suctionability, using hurricane suction and everything, you can remove tumor. But if in the surgery you find the tumor is firm, you can go for extracapsular dissection, but you cannot reach a level more than 1 centimeter above the superior intercalabar size with the extracapsular dissection. Therefore, you go and you change to transplanum approach. Therefore, this is one film of showing the classic surgery. For that case, this is post-operative remove it totally. It happened around 80% of cases. But 20% of cases need something else. This is another case. You see 65% is above the level of ribrosa and the plano. What you see inside there is calcification. The tumor is firm. And why circumcellular dissection? Why cannot remove? You see the tumor reach to the foramen monroe and compress the tumor above and adhere to the internal circle vein and communication artery and everything. This is the movie that I will show you. We remove the tumor to the class 6 corridor. This is a classic corridor tumor removal. Reach here. I think that I removed 80% of the tumor, but I was right. I removed only 35%. Therefore, I changed to the transplanum approach. Find the mouse. open the tumor. I cannot find the notes. I want to jump through this. Okay, we remove the tumor and may you help me? I want to jump because carrier was left before, and because of time, I don't want to show the face. You can remove the tumor. 90% of our inferior cases, we were able to do this. Therefore, the transplanum approach, this is post-op view. You see the fat graph inside. This is MRI the day after surgery. And you see CT scan. We, in some cases, we do MRI the day after surgery. And this is back. Another important case that is subfrontal extension. Subfrontal extension, if you see in large pituitary adenoma, is one of the cases that need transplantal approach, in my opinion, because you will leave the tumor behind. This is the case of subfrontal. This is post-op view. And another case is the lateral extension. Because if you do a transplantal approach, you can follow the both PCOM. You see the PCOMs, but on the anterior cerebral, you should be sure that you don't injure this. This is one of the cases again. This is the preoperatively we did CT angio in lateral extension cases of pituitary. This is the post-op view. And in conclusion, I want to say that using the transplanum approach is good for in large cases, reoperation, multiple reoperation cases, in the cases with some frontal extension, and in cases that you want to show that you want to reach to the lateral side to see the PCOM and the guided bifurcation. Thank you very much.
Thank you, Professor. Sharing question, please. No question. Thank you.
Thank you very much.
Thank you.